Hello guys, this is Dr. SNK up with the next topic, that is systemic microbiology part 1. Here I will be covering the CVS, GIT, hepatobiliary and skin and soft tissue infections. So this is the part 1 of systemic microbiology. In the second half I will be covering RS, CNS and all other topics. Okay. Coming to the topic per se today, it is starting with the CVS, causes of infective endocarditis. It's a 3-marker question for you people. So they're going to ask what are the causes of infective endocarditis. Native valve, I have told in pathology what is a native valve. It has never undergone any infection in its lifetime. Okay, prosthetic valve is the valve which has been undergone the previous infection and it has repeatedly been infected. In the native valve, the cause is Staph aureus, whereas in the prosthetic, if it is early, that is less than 1 year, you are going to see Staph epidermidis. If it is late, it is Streptococcus viridans. Coming to the hack group, which is the most commonly encountered infective endocarditis causes. So the name itself will be abbreviated as hack. So the bacteria under them are Haemophilus, parainfluenza, Aggregatobacter, Cardiobacterium, Eikenella and Kingella. These are the things. So what are the clinical features when it comes to infective endocarditis? You are going to see murmurs, Janvier lesions, raw spots and oscillus nodes. These are the things which you are going to see. Coming to the next topic, that is acute rheumatic fever. It is a non-suppurative lesion. Okay, it is a non-suppurative lesion. So coming to the cause of it, it's a group A beta hemolytic streptococcus. You are going to see the beta hemolysis. That's why it's named as beta hemolytic. Okay. Coming to the clinical features, again murmurs and John C. The mnemonic I have told in pathology, John C. So JO for joints, that is polyarthritis, and N is for nodules, that is subcutaneous nodules, and E is for erythema marginatum, S is for sydenham scoria, C is for the main thing, that is carditis, which is usually a pan feature, that is a pancarditis feature. So what is the type of hypersensitivity? It is a type of type 2 hypersensitivity. Coming to the treatment. In the treatment, it is benzathine penicillin. Okay, benzathine penicillin G, which you are going to give as an IM dose, which is single. Then you can also give oral penicillin 5, that is V, for 10 days. Complications are post streptococcal glomerulonephritis. Coming to the bloodborne viral infections, it is HBV, HCV, HDV and HIV. These are the viruses which are coming under the viral infection spread of the blood. Coming to the parasites causing anemia, Diphyllobothrium laterum, that is going to cause megaloblastic anemia. Then Ankylostoma duodenale will cause iron deficiency anemia. Trichuris trichura is going to cause normocytic normochromic anemia due to chronic dysentery. Then Necator americans, again it will cause normocytic normochromic anemia. Schistosoma is going to cause iron deficiency anemia. Malaria, that is Plasmodium falciparum variety, is going to cause hemolytic anemia, and Leishmania donovani is going to cause aplastic anemia. Then coming to the enteric fever. What is enteric fever? It is also called as typhoid fever. It's a 10-marker question. They will give the case form for you. Typhoid fever. Causative agent is Salmonella typhi. What are the serotypes? A, B and typhi. Okay. See, Salmonella paratyphi A, Salmonella paratyphi B and Salmonella typhi. These are the causes, also the serotypes. It is based on the O antigen. That is a somatic antigen which is present. So what are the antigenic structures? O antigen, that is somatic antigen. H antigen, that is flagellar antigen. VI is polysaccharide antigen. Okay, VI polysaccharide antigen, which is used in the formation of vaccines. Pathogenesis, the most common route of spread is oral route. Okay, oral route, that is through contaminated food or water. Infective days is high, that is 10 to the power 3 to 10 to the power 6. What are the risk factors? Basically hypochloralgia, that is decrease the synthesis of HCl, so that the HCl is not there and the bacteria will start growing inside the stomach. And decreased intestinal integrity, that is due to any of the GI disorders such as inflammatory bowel diseases, prior gastric surgeries, and increased antibiotics usage unnecessarily. Coming to the entry, so how does the entry will be gained? It is through M cells. Okay, M cells in the epithelium is going to be breached by endocytosis mechanism. Once the bacilli enter inside, they form vesicles. Okay, they form vesicles. After forming vesicles, they enter into the macrophages, and the macrophages, they are going to be taken into the blood via monocytes, that is causing primary bacteremia. Mainly the things are liver, spleen, lymph node, and bone marrow. And secondary bacteremia. Clinical manifestations being stepladder fever. Okay, stepladder fever is the most common clinical features encountered. Then headache, chills, cough, sweating, myalgia, arthralgia are the common symptoms as a part of fever. Then rose spots, which are very specific, abdominal pain, nausea, vomiting, anorexia are the things which you're going to see. Then GI bleeding, intestinal perforation. As a part of late things. Coming to the interpretation, in the interpretation you're going to see the titers. Antibody titers are going to be seen, that is H titer and O titer. H is more than 200, O is more than 100. False positive is seen in case of malaria, dengue. Okay, is seen in case of malaria and dengue. If it is co-infected with malaria or dengue, it is seen. Okay, it is seen if it is co-infected. Then fourfold rise is very specific. Okay, fourfold rise is very specific than a single high titer. Okay, if you are going to see increasing the titer after 1 week, it indicates the infection is present. If it is not going to increase or it is decreasing, then it indicates the infection is not there. False negative is seen in case of early and late. Okay, early and late. So patient who are on treatment also will give false positive and antibody excess. Okay, this is how we are going to interpret. So what is basically this interpretation? It is an interpretation of Weil test. It's an investigation choice for typhoid fever in the 2nd and 3rd week. What is the principle here? Agglutination is the principle. So what are the antigens used? O, H and H. Okay, O antigen and H antigen, of whom it is typhi and paratyphi A and B. So what are the results? Basically you are going to see 2 results. One is O agglutination, the other one is H agglutination. O agglutination is granular, it is very granular, whereas H it is fluffy. Coming to the signs of enteric fever: abdominal pain, hepatosplenomegaly, that is HSN, then epistaxis and relative bradycardia are the things you're going to focus on. Okay, then coming to the neurological features which are very late, that is meningitis, cerebral ataxia, and psychosis and delirium. Okay, those are rarely seen. It's better if you don't mention. If you are able to mention, you can mention it as a late clinical features. Coming to the epidemiology, what is epidemiology? Epidemiology is being the study of the diseases. Basically, what is a triad? You're going to see agent, environment, and host. Okay, these are the 3 things you are going to concentrate here. Agent is Salmonella typhi. What is the environment? Environment, usually it is most common in case of what? It is common in case of urban environment, that is in the cities and poor sanitated areas. And host, you are going to see young children and adolescents are the hosts. Okay, fecal carriers and the urinary carriers are the most common carriers. Fecal and urinary carriers. Duration of the shedding is basically on the different carriers. Okay, that is convalescent, temporary, and chronic. Okay, these are the types of the carriers you are going to see. So what are the lab diagnoses? You are going to remember a name as BASU. Okay, this is how you are going to remember the lab diagnostic, BASU. Okay, so basically in the first week you are going to do the blood culture, that is B for blood culture. A is for antibody detection, that is done in the 2nd week. S is for stool culture, again it is done in the 3rd week. Same way, U is for urine culture, it is done in the 4th week. Coming to the Weil tests, I told you it's an investigation of choice. Principle is agglutination. You're going to use O and H antigens. What are the results? Granular, chalky O agglutination and fluffy H agglutination. You're going to interpret based on the antibody titer. So what is the antibody titer? If it is more than 200 for H and more than 100 for O, it is significant. Okay. What is the treatment? Basically, you're going to give the empirical treatment before giving any of the following to protect from the severe effects. So, ceftriaxone and azithromycin are the empirical form of treatment. If they are susceptible, then you're going to give ciprofloxacin. If they are fully susceptible, you can give ciprofloxacin. If it is multi-drug resistant, again you can give ciprofloxacin. Okay, ciprofloxacin can be given. For carrier, you can give ampicillin. Okay, or cotrimoxazole. Vaccine. Coming to the vaccine, there are 3 vaccines: TAB vaccine, VI polysaccharide vaccine, and typhoid. These are used in case this is not used now. Presently, TAB vaccine is not used. VI polysaccharide vaccine and typhoid vaccines are in use. Okay. Coming to the next disease, that is Q fever, which is for 5 marks. So basically, what is a causative organism? What is a causative organism? Coming to the causative organism, it is Coxella burnetii. It is Coxella burnetii. It is gram negative and resistant to physical and chemical agents. Okay, it is resistant to all of the methods. It is resistant to most of the methods of sterilization, and it is not cleared as a part of pasteurization also. It is a zoonotic. So basically, bandicoot is the animal which is being used, which is working as a primary reservoir. The soft tick is being the reservoir sometimes, and even exotic tick also. Risk factors: people who are in contact with the animal feces and the products are the things for the risk. Coming to the route of transmission, it is consumption of infected milk, handling of infected wool. Okay, infected milk, infected wool. Okay, infected milk and infected wool. Contaminated soil. Okay, contaminated soil and clothing. So again, same contaminant features, that is headache, chills, myalgia, fatigue, malaise. All these are the things you're going to write. Never mention rash here. Okay, respiratory difficulty is seen, fever also is seen, abdominal pain is also seen, but never write rash here. Q fever is without rash. Okay. Types: acute and chronic. In the acute, it is going to involve the surrounding structure, that is most commonly liver, and in the chronic it is endocarditis. In the chronic it is endocarditis. In the acute it is fever plus hepatitis. Lab diagnosis, again complement fixation test to diagnose it, and indirect immunofluorescence being the investigation of choice. ELISA to detect the antigen and the antibody, and Weil-Felix test. Okay, Weil-Felix test, which is always negative. Remember, it is not positive here. Prevention: careful. Okay, how we are going to prevent it? Careful handling with the animal and its products. Okay, in a proper manner. Coming to the Weil-Felix test, it is a heterophile agglutination test. I mentioned in the immunology, heterophile antigen having the same haptens. They are sharing the same haptens. Okay, so they are going to cross react with. So what is the use of this test? It is going to use the Rickettsial antibodies. Okay, Rickettsial antibodies are being detected using the protease antigens. Okay, protease antigens, that is LPS antigen. Okay, LPS antigen. What is the procedure? Tube agglutination. Again, it is a tube agglutination test. The procedure and the principle is being agglutination test. Results: if it is OK 19 positive, it is epidemic and endemic, both positive. If it is 19 and 2 positive, it is tick-borne spotted fever is seen. If it is K positive, it is scrub typhus. Okay, K for scrub, 19 and 2 for spotted. You're going to spot 2 friends together, or 2 male and female together. Okay, then it is spotted fever. Remember like this: 19 epidemic and endemic. Coming, if it is negative, it is in case of rickettsial pox fever, Q fever, and Bartonella. I have told, right? Weil-Felix is negative in case of Q fever, I just mentioned before. Then false positive is seen in case of protease infection, because the protease antigens are going to be increased. Then coming to the false negative, it is excess of antibodies, that is called as prozone phenomena. Weil-Felix test is just a screening test. Okay, it's just a screening test. It is not sensitive. It should always be confirmed by immunofluorescence and ELISA. Then coming to the rickettsial diseases and the vectors. there are three groups. One is typhoid group, then spotted fever group, and scrub typhus. Okay, basically the two typhus are epidemic typhus and endemic typhus. Spotted fever are Rocky Mountain spotted, and rickettsial pox are the two seen. In the scrub typhus, it is alone the disease. So we are going to see the vectors, the things now. It is caused by Rickettsia prowazekii. Epidemic is caused by Rickettsia prowazekii, whereas Rickettsia typhi is going to cause endemic. Rocky Mountain fever is caused by Rickettsia rickettsii, and Rickettsia pox is caused by Rickettsia acari. So then one more you are going to see Indian tick typhus, which is a part of spotted fever only. Here it is Rickettsia conuri. So we are going to see the vectors now. So epidemic, it is louse. Okay, epidemic we are going to see louse. Epidemic it is louse. Endemic it is flea. Rocky Mountain again it is tick. Okay, Rickettsia pox it is mite. Okay, then Indian tick typhus it is tick. So how you are going to remember this? How are you going to remember this? Tick is for Rocky Mountain. Okay, the Rocky Mountains are famous in our India. Okay, that's why hilly Rocky Mountain, Himalayas, which are very famous all over the world. They are the tallest peaks. That's how you're going to remember. They are at the peak, and there is tick there. Peak, tick. Okay, so Rocky Mountain fever and Indian tick typhus. These are the two which is having tick as their vector. Then coming to the rickettsial pox. Rickettsial pox is caused by mite. Endemic and epidemic you're going to remember simple. Okay, endemic, and so epidemic is done by louse, and endemic is flea. Brucellosis is the next disease which you are going to concentrate. In the brucellosis is basically a primary zoonotic disorder. Remember, it is a zoonotic acquired from animals such as sheep, cattle, and goat. There are three species: Melitensis, abortus, and canis. Melitensis will be in sheep and goat, abortus in cattle and buffalo, canis in dogs. Pathogenesis, most common organism here you are going to encounter is Brucella melitensis. Transmission is basically the direct contact with the animal product. Okay, direct contact with the animal products. Then raw milk and airborne also seen. Most common organ to be affected is reticuloendothelial system. Incubation period is very long, that is from 1 week to several months. Clinical features you are going to see fever with night sweats, with arthralgia and arthritis, and hepatosplenomegaly is the classical triad. Okay, fever with night sweats, with bone pains, and hepatosplenomegaly. Typhoid like illness. Okay, it is causing typhoid like illness, and that's why it's called as undulating fever. And it is a less severe form. Coming to the lab diagnosis, in the lab diagnosis it is culture and identification. It is using the samples such as blood, bone marrow, and CSF, and media which is used for this is BHI, broth, or agar. Since Brucella being a anaerobic, we are going to do it in anaerobic culture media, which I mentioned in the general, that is BHI, brain, heart, infusion, broth, or agar. Okay, antibody detection is basically on standard agglutination test. It is gold standard. It detects the IgM antibodies, okay, against the LPS of the Brucella. Then false negative is seen in case of again proton phenomena, and non-agglutination. If there is non-agglutinating IgG or IgA, these antibodies, they are not going to bring about any agglutination, and they will lead to false negative results. Coming to the complement fixation test and ELISA, these are the nuclear methods. Other tests such as PCR again. Coming to the treatment, in the treatment the standard regimen is streptomycin and doxycycline. Okay, remember one regimen, that is streptomycin plus doxycycline. According to WHO, it is rifampicin. You can give rifampicin also with doxycycline. If CNS involvement is there, you are going to add the ceftriaxone. Okay, ceftriaxone is being added. Then next disease is HIV. Okay, human immunodeficiency virus. Morphology, this is how we are going to draw the morphology. It is envelope. Okay, the enveloping proteins are GP20 and GP41. Okay, the first you are going to draw the inner RNA. Okay, inner RNA. Then reverse transcriptase enzymes. Next, covering them is the capsid, which is made up of P24. capsid protein. Then out of it you are going to see the P17 matrix proteins. Out of that you are going to see the lipid bilayer. In the lipid bilayer you are going to see two enveloping proteins, that is GP120 and GP41. Both of these together they forms GP160. And it is icosahedral. I'm not able to draw. I'm not good in drawing, so make sure you draw it properly. You're going to draw this capsid in a icosahedral, that is benzene shaped. Structural genes are GAG gene, pole gene and envelope gene. Okay, just remember them, it is sufficient. Then non-structural genes are TAT, NEF, LTR. TAT, NEF. How I used to name is GAG pole, TAT, NEF. GAG pole, TAT, NEF. That's how I remembered. Just two genes from each. If you are going to remember all, it gets sufficient. Then LTR is the last. It is long terminal lipids. Next, we will be dealing with pathogenesis. Coming to the mode of transmission of HIV, most commonly it is sexual. Coming to the others, it is IV drug abuse, parent to the child, that is vertical transmission, blood transfusion and needle prick injury. These are the things. Receptor attachment and fusion. Okay, receptor attachment and fusion, that is by GP120. CD4 receptors on the host cell, that is the TH cells, is being attached by the GP120 things of HIV. For fusion it is now CXCR4 and CCR5. Replication is penetration and uncoating. Okay, replication is basically on penetration and uncoating. So it will come inside now. Once it is attached, it is going to come inside for replication. So that is done by, first is penetration. It is coming inside penetration. Then it is getting uncoated. Outer capsid things and all are moved. Then integration with the DNA chromosome. Then lastly bring about the latent infection by repeated things. So HIV RNA is converted to HIV DNA is basically by reverse transcriptase. Okay. Then virus double-stranded DNA is integrated with the cell chromosome using an enzyme called as integrase. Then stages of HIV. I have told it in the patho also. First it is acute disease, then asymptomatic disease, then persistent generalized lymphadenopathy and symptomatic disease. Okay. Lab diagnosis. What are the lab diagnoses you are going to do? Screening tests. Okay, screening tests such as IgG antibody detection, that is specific. Then CD4 T cell count is also done. Antibody detection, if it is there, you are going to barilebeku ELISA, you must write. Okay. Then rapid antigen test also can be done, rapid antibody detection. Then supplementary tests. Western blot assay and immunofluorescence assay. These are also specific. They are supplementary tests. Then lastly confirmatory. You must confirm, right? For that you are going to do P24 assay. Then viral culture, HIV RNA, HIV DNA. HIV RNA is done for gold standard for most of the cases, that is RT-PCR, branched DNA assay and real-time PCR to quantify the viral load. Then remember DNA for pediatric people. Coming to the NACO strategy of HIV diagnosis, you are going to use it in resource poor. Okay, resource poor countries, you are going to do HIV diagnosis in NACO formality. Then HIV by PCR. Okay, PCR and Western blots are not used. Okay, basically if it is not there, then these are the things which are done. So basically first and second test should be more of sensitivity to say that this person is having that disease. Then third and fourth test which are being used should have more specificity. So specificity is ability of a test to say no, the patient doesn't have the disease. Strategy 1. So in the strategy 1 you are going to do blood transfusion people and transplantation people, you are going to do the NACO diagnostics. Then 2A, it is based on zero prevalence. Then 2B, HIV symptomatic patients. Then 3 is for HIV asymptomatic patients. Okay. Prognosis and monitoring, CD4 T cell count, HIV RNA load and P24 antigen detection. Most commonly it is used is CD4 T cell count. Okay, CD4 T cell count. Pediatric HIV diagnosis is basically HIV DNA, most commonly recommended, but you can also do ELISA, that is IgG detection, only after 18 months, only after 18 months, remember. Window period diagnosis is basically done with P24 and HIV RNA. HIV RNA you have seen everywhere, it is there, so it is the most common recommended. You can do anything HIV RNA, all those things, except HIV DNA is in pediatrics. So window period is the initial time interval between the exposure and appearance of the detectable levels of antibodies in the serum. Okay, coming to the opportunistic infections, it's a 3 marker and a 5 marker. If you are going to explain, it is 5 marker. If you are going to just mention them, it is 3 marker. So CD4 count is very important here. Based on the CD4 count, the infections are being spotted. So coming from 800, it is normal. Coming to 600, okay, CD4 count if it is 600, then the initial such as lymphadenopathy and thrombocytopenia will start developing. In the 500, you're going to see the skin infections. Then HSV, zoster. These are all skin infections only. Again, oral candidiasis. You're going to see oral candidiasis. 400, in the 400, Kaposi's sarcoma is very uniquely seen. At the 300 level, it is hairy leukoplakia and TB will start setting in. 200, it is pneumocystic carni pneumonia, okay, that is pneumocystis pneumonia. Then cryptococcosis and toxoplasmosis, okay, these are seen. Ultimately in the last, that is 50, you're going to see MAC, that is Mycobacterium avian complex infection, CMV and lymphoma. These are seen at the last, okay, primary effusion lymphoma because of Kaposi's sarcoma also. Then so many other things, adult T-cell lymphoma, which is called by HTLA4, okay, HTL4. Coming to the treatment of antiretroviral, that is antiretroviral, you're going to see TLD regimen, okay. Recently it was given in your Pharmac paper, right? So antivirals, in the antivirals you're going to write the TLD regimen, tenofovir, okay, tenofovir, lamivudine and dolutegravir, right? Dolutegravir. Then post-exposure prophylaxis, again TLE here it is E, that is tenofovir, lamivudine and efavirenz. It's been updated, I think most probably it is TLD regimen in the both. So basically it's better if you write TLD regimen in the both, okay, it's fine. You can write TLE regimen also, TLD regimen also. So it should be started as soon as possible, that is within 2 hours. It must be started within 72 hours. It must be started, or else it is not effective. What is the indication? Healthcare workers who are exposed to positive cases of HIV and any kind of exposure to the blood and blood products related to the infected patients. Precautions: safe sex, safe clinical practices, okay, spread awareness and camps regarding it, sex education, okay, avoid unwanted exposure to the infected people, safe sex using condoms, okay, there are physical barriers. Then safe clinical practices using double glove for the positive patient, then spreading awareness and caps and eradicate the social stigma of the disease, and sex education regarding the having the safe sexual practices and advantages of using the condoms, okay. There are other advantages also, such as contraceptive measure, okay, it can lead to contraception also. If the people are having so much of kids, it's helping in contraception. Coming to next disease, that is dengue, okay. Dengue is the most common arbovirus infection in India. What is the vector here? Aedes aegypti, daytime bite, usually it is daytime bite of Aedes aegypti. Pathogenesis: firstly it will cause primary infection, then it will cause secondary infection, okay. Route of transmission is mosquito bite, which is infected, and inoculation into the bloodstream. Secondary infection is due to the other serotype. If suppose primary infection is because of DEN1, then secondary is infection because of DEN2, and it is the most common combination, and it is the most dangerous also. And this type of pathogenesis is basically, that is secondary infection is due to antibody dependent enhancements. Our antibodies itself will provide a bed for the secondary serotype infection, and that is called as antibody dependent enhancement, ADE. What are the clinical classification? Classification are dengue fever, dengue hemorrhagic fever, okay, that is old, and last is dengue shock syndrome. These are the old classification, remember, but these are important. Even if it is old is gold, okay. Dengue fever, you're going to see increased fever, maculopapular rash, headache and joint pains and nausea, vomiting in the initial stages. Whereas in dengue hemorrhagic fever, You're going to see again high fever, continuous high fever, hepatosplenomegaly, thrombocytopenia, increase in HCT, petechiasis, and spontaneous bleeding from gums, nose, and stools. Okay. Thrombocytopenia is when less than 1 lakh and HCT by 20%, and petechiasis you should see more than 20 in square meters. Okay, in square area meters. Okay, area per square meters. Coming to the dengue shock syndrome, again the same DHF, that is dengue hemorrhagic fever associated with the shock symptoms, then it is called dengue shock syndrome. Okay, what is the new classification here? Dengue with or without warning signs, with or without warning signs. Other one is severe dengue. Simple. Now they have made simple. Severe dengue with or without warning signs. Lab diagnosis is basically on NS1 antigen. NS1 antigen. In the NS1 antigen, again it is basically ELISA and immunochromatography. Okay. Early detection and highly specific. It is early detectable and highly specific. Antibody detection is basically IgM after 5 days. Okay, IgM after 5 days and IgG in the primary infection. Okay, IgM and followed by IgG in the primary infection, whereas rise in the IgG singly, alonely. Okay, if you are going to see just rise in IgG, it indicates secondary infection. You are going to do ELISA also. You are going to do MAC ELISA, that is going to detect the IgM and IgG separately. Other antibodies detection are hemagglutination. Okay, other antibody detection tests are hemagglutination, then CFT, that is complement fixation test. Vaccine is CYD-TDV, that is live attenuated tetravalent vaccine, using the yellow fever. Okay, using a yellow fever. What are the causes of hemorrhagic fever in the viruses? Dengue, yellow fever, Kaisner forest disease, which is holding the priority in our state, that is Karnataka, most commonly seen in Shivamogga, Chikmagaluru, Madikeri, and all those things, Uttar Kannada, Udupi. Here the monkeys are the most common animal reservoirs, whereas humans are also seen presently. So many other diseases are also being reported related to the KFT in humans. It is most commonly transmitted by soft tick, or there are no vector only for it. Okay, that are the things you must remember, and it is endemic in Karnataka. Then OMSK hemorrhagic fever, OMSK, okay, OMSK, okay, OMSK hemorrhagic fever. Then Crimean Congo hemorrhagic fever. Okay, in the name itself they are going to cause hemorrhagic fever. That's how you're going to remember Crimean Congo and OMSK. What are the complications of dengue fever? What are the complications? Septic shock. Okay, septic shock, organ damage, that is MODS, multi-organ failure. Then ALDS with pneumonia. Okay, pneumonia, it will cause pneumonia, and last acute respiratory distress syndrome. Then spread from mother to child. Spread from mother to child will cause preterm labor, low birth weight, and respiratory distress syndrome in the baby. Okay, preterm labor is a labor related complication. Then low birth weight and RDS is post-term, that is after the delivery in the babies, that is the pediatric complication. In the neurological complications you can see stroke, palsies, and encephalopathies in the late stages. So arboviral infections. What are the arboviral infections? They are going to ask name the arbovirus infections. Dengue, chikungunya, okay, Japanese bee encephalitis, Kaisner forest disease, okay, Crimean Congo fever, West Nile encephalitis, West equine encephalitis, East equine encephalitis. All these are the arboviral infections. Next disease is malaria. Causative agent is Plasmodium falciparum. Other species are Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria. What is the life cycle? Basically, the definitive host is female Anopheles, intermediate host is man. So the sporozoites which are present in the salivary gland of the Aedes, after the bite, it is going to be transformed into trophozoites once it's entering into the RBCs. So basically, these trophozoites, this is not included. Sorry, I'm not. Don't write them here. Merozoites are formed later, not here itself. Okay, they are not formed here itself. So once these trophozoites are inside the RBCs, they are going to later form the gametocytes. This is what the life cycle. So if you want to remember the separate life cycles, that is asexual life cycle and sexual life cycle. In the asexual life cycle, that is liver cycle and RBC cycle are the commonly seen, that is seen in the human, whereas sexually it is seen in case of female Anopheles mosquito. Asexual, in the liver cycle, first sporozoites are formed. From the sporozoites it is going to be forming into tropozoites, and the tropozoites later will form pre-RBC cyjoints, and later pre-erythrocytic merozoites are formed. So once these merozoites are formed, they are going to enter into the RBC cycle. In the RBC cycle, first they are going to form the pre-erythrocytic merozoites. What they form? They form early trophozoites, that is ring forms, then late trophozoites, and lastly it is erythrocytic cyjoint leading to merozoites. This is the asexual cycle. Sexual cycle is the gametocytes enter into the infected Anopheles and gametes are formed. So the gametes later they form the zygote and oocyst, lastly sporozoites. Again the sporozoites are injected into the body via the mosquito bite from the salivary gland of Aedes. Recrudescence, okay, recrudescence is seen, okay, and due to the resistance it is repeatedly coming, okay. If the treatment is failing, that is seen in case of Plasmodium falciparum and Plasmodium malariae, and it is due to drug resistance, and long-term RBC survival, because their incubation is very large, okay. Long-term RBC survival. Relapse, okay, repeated infection due to hypnozoites. These, what I told, sporozoites, they go and enter into the liver and they stay there for long duration, and they reactivate to form the merozoites, okay. That's why these hypnozoites will lead to the relapse. That is most commonly seen in Plasmodium vivax and Plasmodium ovale, and the treatment for it is primoquine. Pathogenesis, okay, how is it formed? Basically, first there is sequestration of this particular parasite inside the major organs such as spleen, kidney, liver, and this. So after that it is sequestrated, it is get you, and it undergoes rosetting and cytoadherence. Cyto means cell, so it is going to adhere to the cell, and there is rosette formation. These are the two things which is a part of sequestration. Then once these are sequestered, our body will not leave it simply. It is going to identify that this is particular malaria is going to stay and it is hiding there. So for that our immune system will produce a strong response, and the response are basically keyed or based by cytokines, and that is activated by whom? Glycosyl phosphatidyl inositol. Risk factors. What are the risk factors basically? So the risk factors are rainfall, high rainfall conditions, okay, high rainfall conditions, altitude less than 2000, then density of the vector is more, and humid areas, okay, density is more. Right now I have not written here, density of the vector is more. Then clinical manifestations. Coming to the clinical manifestations, fever with chills or rigors, okay, typical presentation, fever with chills or rigors. Then anemia, that is hemolytic. I told, right, malaria will cause hemolytic anemia because of breakdown of the RBC, because they are forming inside the RBC. Who is forming there? Tropozoites are forming there, and they are going to damage the RBCs. Then splenomegaly due to sequestration. Then irritability, coma, algae malaria, and respiratory distress syndromes are seen as a part of clinical manifestations. What are the complications of malaria? They are going to ask it for 3 marks. Remember the cerebral malaria, okay, black water fever, then tropical splenomegaly syndrome, then malarial hyperpyrexia, malarial hyperfever, okay, then GI syndromes, algid malaria, nephrotic syndrome, Burkitt's lymphoma, and acute tubular necrosis. These are the complications of malaria. Coming to the lab diagnosis, basically the lab diagnosis is mainly because of the peripheral smear, okay. Most commonly it is encountered as a part of peripheral smear. It is thick smear and thin smear. Thick is because to quantify how much it is present. Thin is to identify the species. Thick is for quantification, that is to identify how much it is present, and thin is for species identification. Special stain is JSP stain, which was developed in India only, but most commonly we use Leishmaniasis and Gibson, okay. Jashwant Singh's and Bhattacharya stain, something like that, okay. I don't remember full name, you just see. Then fluorescence microscopy. Fluorescence microscopy is basically using the acridine orange. Okay, fluorescence microscopy. And quantification Buffy test. Okay, quantification Buffy test for rapid identification. You're going to see the 3 layers there, and that is not required in detail also. These are all the microscopic tests. What I mentioned is microscopic test. Now coming to the non-microscopic test, you're going to see antigen detection. Then PLDH. Okay, PLDH detection. Then HRP2 antigen detection. Okay, these are all antigen detections. Then antibody. It is epidemiological survey and screening. Okay, these are the 2 conditions where you are going to use the antibody detection, that is epidemiology survey and screening in the blood bank. Then PCR is also used. Treatment uncomplicated, you are going to just use chloroquine. Complicated, you are going to use the artemether and artesunate components. That is artemisinin combination therapy. Leishmania. The causative organism is Leishmania donovani. What is the mode of transport or mode of transmission? It is bite of the sandfly. Sandfly is the vector, remember. Sandfly is the vector. Sandfly, it is going to bite during the late evening or the night time. Whereas dengue, it is daytime. Remember, it is daytime. Disease, Kala Azar. What is the disease caused? It is called Kala Azar. Why is it called Kala Azar? Kala means hyperpigmentation. Azar means fever. Okay. They're going to say in fever, what do you call fever in Hindi? I don't remember. Bukar, right? So Azar, Bukar. That's how you going to remember. Bukar, Azar. Then associated with hepatosplenomegaly. Then lymphadenopathy, anemia, leukopenia, and thrombocytopenia. These are the things. Kala Azar in HIV, it is a bit different in HIV. How is it going to be presenting in HIV? That is, there is no hepatosplenomegaly and it is associated with GIT symptoms, and it is most common in sub-Himalayan regions. PKDL, post Kala Azar dermal Leishmaniasis. Okay, it is a 3 marker. First of all, you are going to write it's a complication of Kala Azar. It is seen in children. And after treatment, usually after treatment, and the incidence is 2 to 20% in India. So what are the clinical features? It is non-ulcerative hypopigmented macular lesions. Okay, non-ulcerated hypopigmented macular lesions, which will become nodular later. So it will persist for more than 20 years. Okay, it's persisting for 20 years. So what is the treatment here? Long course of antimonials you are going to give. What are the types? Cutaneous, mucocutaneous, and visceral are the types of the Kala Azar. Okay, not types of the infections of Leishmania. Not the types of Kala Azar. Cutaneous Leishmaniasis, it is called belly boil. Mucocutaneous Leishmaniasis, it is called Espendia, and visceral, it is called as Kala Azar. Here the organism is Leishmania tropica. Here it is Leishmania brasilensis. Here it is Leishmania donovani. Coming to the life cycle, first there is something called as sandfly bite. After the sandfly is getting bited, the pro-mastigote forms are injected into the macrophages, and they are going to transformed into amastigote form. Okay, amastigote forms are intracellular, whereas pro-mastigote is extracellular. So intracellular multiplication of the amastigotes are going to be seen. That is, multiplication takes place after the amastigotes are released. They are released to infect the others. Then the same sandfly bites and ingests the amastigote forms. What happens once these amastigote forms are injected? It is going to complete its life cycle. Okay, and they are transferred into pro-mastigotes in the gut of the sandfly. Infective form is pro-mastigote. Diagnostic form is amastigote. Remember. So this is how we are going to draw. You are going to draw it like this, and you are going to draw 2 dots. In the first dot is kinetoplast. Okay, the other one is the flagella. Amastigote, you are going to draw it cell, that is a macrophage consisting of amastigote forms, that is LD bodies. They are called as LD bodies. What are LD bodies? Basically, Leishmania donovan bodies. They are oval shaped amastigotes in cytoplasm of bone marrow. Okay, they are oval shaped amastigotes where in bone marrow, liver and spleen. Indication, what do they indicate? They indicate visceral leishmaniasis is going on inside the body. And what is the treatment of them? It is liposomal amphotericin B. Coming to next, that is microfilaria. Microfilaria. Microfilaria is basically seen after provoking it with diethyl carbamazepine. Okay, carbamazine. Sorry, not carbamazepine. Carbamazine. So it is a microfilaria, larval form of what? It is a larval form of filariasis disease. It is a larval form of filarial disease. It is diagnostic. There are 4 patterns: Bancrofti, Malai, Weil-Felix and Loa. Wuchereria bancrofti, Brucellosis malai and Onchocerca Weil-Felix and Loa are the subtypes. So how we are going to differentiate the microfilaria? All will be having sheaths. All are having sheaths except Onchocerca Weil-Felix, that is sheathless. Okay. Then both of the organisms, that is Wuchereria and Onchocerca 1 and 3, 2 and 4. Remember like this. 1 and 3 will don't have the tip nuclei. There is no tip nuclei, whereas there is big nuclei in case of Wuchereria malai. Okay, malai kofta, malai will be round. So remember like this. So that is round, big nucleus at the tail tip. Whereas Loa, so it is multiple. So Loa is multiple, right? So it is repeating. The Loa is repeating again. So Loa multiple. They are multiple small nuclei. How is the Loa? It is very small. Whereas Brucellosis malai is kofta malai. Okay, or it is huge. Remember like this. Then diethyl carbamazine is the drug of choice also, and it is also used for diagnosis as a provocation test to demonstrate the microfilaria in the daytime. These are very notorious. Okay, these microfilaria, they don't come out in the daytime and they are always hiding. Once in the sleeping time, that is in the night, they come out and they cause massive infection. So we are also very smart. So we are going to give them and challenge them that there is some already anti-helminthic, come outside like that, or else you will die. Okay, you are going to do the blackmail for them. If you don't come outside, you are going to kill your other things. Okay, you are going to kill your families. Same way here the microfilaria is being targeted or challenged by the diethyl carbamazine. If they are seen, it is diagnostic of filariasis. If they are not found, where and all it is not found, occult filariasis and chronic filariasis, you are not going to see microfilaria. What is the treatment here? Diethyl carbamazine plus albendazole. Okay, but for Onchocerca Weil-Felix, it is ivermectin. Next, fungal, that is histoplasmosis or Darling's disease. Causative agent is Histoplasma capsulatum. Reservoir, humid and acidic soil. Okay, transmission, inhalation. Okay, inhalation of the spores. Then clinical features: pulmonary is the most common, acute and chronic. Acute being flu-like illness, and chronic it is cavitary lesions. Then mucocutaneous lesions and disseminated in case of HIV patients. Okay, in case of HIV patients, what you are going to see in histopath? You are going to see tiny oval cysts with narrow base budding. If you are going to see broad base outward, it is blastomyces. Base is broad, so it is blasto. So next, coming to the culture of this things. Gold standard. Okay, gold standard dimorphic fungi at 25 degree. You are going to see the septate hyphal forme with tuberculate microconadia and creamy white colonies, that is yeast form. You are going to see intracellular yeast forms. I told it is the only intracellular fungi. It is the only intracellular fungi. Antibodies in serum through complement fixation tests and immunodiffusion tests. Okay, with this we are done with the CVS. Coming to the GIT. It is gram-negative bacilli. We are going to focus on E. coli, which is very common. It is a gram-negative bacilli. It is aerobic and lactose fermenting. These are the things you must remember. So what are the clinical features or what are the infections caused by the E. coli? They are going to ask UTI, diarrhea, secondary bacterial peritonitis. SBP means secondary bacterial peritonitis. P is for pneumonia, meningitis, then wound and soft tissue infection, osteomyelitis and septic shock. So what are the toxins produced basically? There are 3 toxins. We are going to compare these two and rest others one I am going to write later. First is heat labile and heat stable. What do you mean by labile? It is not stable with heat. Okay, that is why it's called labile. It is produced by enterotoxigenic E. coli. Heat stable is produced by enterohemorrhagic E. coli. There are 6 strains of diarrhenic E. coli. I will be telling you later. So this ETEC, that is toxigenic, it is toxigenic, right? So it is producing toxin and it is similar to whom? It is similar to cholera toxin. It is similar to cholera toxin. So there are 2 fragments A and B. A is going to cause ADP ribosylation and that will increase the cyclic AMP leading to diarrhea. Whereas B, it will bind to GM ganglioside receptors on the intestinal epithelial cells. Then enterohemorrhagic E. coli will bind to the guanylate cyclase and increase cyclic GMP leading to diarrhea. Remember, this is plasmid coated. Okay. Other toxin I told, right, that is verocytotoxin or Shigella toxin. Verocytotoxin or Shigella toxin. What is the mechanism here? B is globotriacyl ceramide, that is GB3 receptor in the intestinal epithelium. A is for inhibition of protein synthesis by inhibiting the ribosome. So coming to the UTI, which is most commonly done by the uropathogenic E. coli. What is the route of spread? Ascending route and descending route. Ascending route is via what? You are going to see the ascending route from the lower bladder and the urethra. The infection is ascending. That is ascending UTI. And if it is descending from the kidney and the pelvis, it is descending down towards the bladder and urethra. It is called as descending route of UTI. Types of UTI: lower UTI and upper UTI. Lower UTI is cystitis and urethritis. Upper UTI is pyelonephritis. Here it is complaining of dysuria, urgency and frequency. Whereas upper UTI, you are going to see fever, vomiting and abdominal pain. Here it is ascending. Here it is descending. Fimbriae is the virulence factor here. Here it is the capsular K antigen. What are the risk factors? Females. Why females? Because they have short urethra and it will provide a early infection. Then pregnancy, catheter, prolonged use. Okay, prolonged use of catheter. Then benign prostatic hyperplasia due to compression of the urethra. There is urine stasis and the stasis urine will undergo infection. Then urinary stones because they are obstructing the normal urinary flow, that will lead to stasis. Lab diagnosis, basically sample collection, that is specimen collection is from the clean voided midstream. Okay, you are going to collect the midstream urine. Then suprapubic aspiration in case of coma and infants. Then urine from the catheter tube, you are going to collect from the catheter tube, not from the bag, remember. Okay, transport via refrigerator. Okay, you are going to add the boric acid and keep it stable. Then direct examination, you are going to do the wet mount to see the pus cells. Then gram staining to see the gram negative rods. Then leukocyte esterase test positive, nitrate reduction test positive and catalase positive. Culture. What is a culture? McConkey agar. You're going to see the lactose fermenting pink colonies and clade agar again for urine samples. Cass concept. What does Cass concept indicate? If it is more than 10 to the power 5 only, if the count is more than 10 to the power 5 only, it is called as significant bacteria. If it is less than that, it is not significant. Remember, that's it sufficient. Then antibody coated bacteria test to differentiate between upper and lower UTI. Then biochemical test, that is ICUT test, ICUT tests. Indole positive, citrate negative, urease negative and triple sugar iron, that is acid by acid with gas positive, and you are not going to see the H2S. Usually diarrhea which is acquired by E. coli will be multi-drug resistance as it is a hospital acquired infection. So we're going to give carbapenems and amikacin, broad spectrum antibiotics, or you can give beta-lactams or beta-lactam inhibitor combinations. So what are the E. coli causing diarrhea? Here I have written enteropathogenic. P for pathogenic, it is causing pediatric diarrhea, that is called as infantile diarrhea. Okay, it is specifically having attaching and effacing lesions. Then enterotoxigenic, it is causing T for travelers diarrhea, using the labile toxin. Then enteroinvasive, it is not toxigenic but it is invasive. Then enterohemorrhagic, it is having Shigella-like toxin and verocytotoxin which is similar to the Shigella, leading to hemorrhagic colitis and HUS, that is hemolytic uremic syndrome. Enteroaggregative leads to acute diarrhea using yeast 1 toxin. Then diffusely adherent E. coli, Coming to Shigella, it is also called as bacillary dysentery. Causative agent is Shigella dysentery. Transmission is ingestion through contaminated. Ingestion is the route of transmission. The infective dose is very less. Remember, 10 to the power 2 is sufficient to cause the infection. So bacilli will enter via M cells. Then invasion is mediated by large virulence plasmid. Plasmid is going to help for the invasion. Then direct cell to cell spread using the active polymerization. So cell to cell, one cell will spread the infection to the next cell using the active actin polymerization of the host cell. Then exotoxins and endotoxins, these are the two toxins. Exotoxins are Shigella enterotoxin, that is Shigella flexneri, that will cause food poisoning. Then Shiga toxin, that is going to cause dysentery, that is Shigellosis. Then endotoxins will lead to intestinal inflammation and ulceration that may lead to the septic shock as the progresses. Then complications, intestinal toxic megacolon, perforation and prolapse are the complications. In metabolic, you are going to see hypoglycemia, hyponatremia and dehydration. Then toxic encephalopathy as part of CNS. Then it is associated with autoimmune disorders. Okay. Then HUS and hemorrhagic colitis. I told right, HUS and hemorrhagic colitis. Then rarely you are going to see septic shock, meningitis and pneumonia. Then lab diagnosis is basically the mucus flakes which you are going to take from the stool, and you are going to study that stool, okay, using the culture microscopy. Okay, culture, you are going to do the culture. In that, first is transport, you are going to transport it safely. Then you are going to use the selective media and you are going to enrich that particular thing. So transport media is basically Carey Blair's media and Sachs bufferol glycerol saline. Okay, then selective media is DCA and Shigella salmonella. Enrichment is using salinity of broth. Biochemical reactions or biochemical things you are going to remember, it is non-motile, non-lactose fermenting. NLF means non-lactose fermenting. It is catalase positive, except Shigella dysentery, it is catalase negative. What are the treatments? Ciprofloxacin is the drug of choice, or you can also give ceftriaxone, azithromycin, with always the ORS, that is oral rehydration solution. What are the clinical features? I forgot to mention there, so I have written here. So clinical features of Shigellosis are watery diarrhea. Okay, there is watery diarrhea, but with that watery diarrhea, what you are going to see? There is mucus flakes or blood. Okay, bloody stools. Okay, it will be watery mixed with blood and mucus with abdominal cramps, fever, nausea, vomiting as usual. Then what are the types of E. coli which are going to cause diarrhea? That is diarrhogenic E. coli, enteropathogenic, I told, pathogenic E. coli, that will cause pediatric or infantile diarrhea. P for P, pathogenic will cause pediatric diarrhea or infantile diarrhea. It is non-toxigenic and non-invasive. In the name it is just pathogenic, so there is no toxin, there is no invasion. Usually it is having attaching and effacing lesions. Then coming to the enterotoxigenic E. coli, since the name has it, it is toxigenic, but there is no invasion there, so there is no invasion. T for T, toxigenic will cause travelers diarrhea. Then it is attaching using the colonization factor antigen. Okay, it is attaching via this. It is producing what? It is producing labile toxin that will increase the cyclic AMP levels. Okay, and that is causing diarrhea, and stable toxin is also produced and that will lead to cyclic GMP, again diarrhea. Entero-invasive, it has invasion there, but it is not toxigenic. Okay, it is not toxigenic because it doesn't produce any toxins. It will cause dysentery. Entero-hemorrhagic, it is again low infective dose, 10 to the power 2, so sufficient it is, and it is producing Shiga toxin that is similar to the Shigella. Okay, then Shiga light toxin or virocytotoxin. It is causing the complications such as hemorrhagic colitis and hemolytic uremic syndromes. Then entero-aggregative E. coli. So that is producing yeast 1 toxin, leading to the acute watery diarrhea using what? Aggregative adhesion fimbriae. AAF. So diffusely adherent. Last is diffusely adherent. Diffusely it is going to adhere to the cells. Okay, intestinal epithelial cells. Diffuse adherent is seen, and that will cause same like as aggregative, leading to acute watery diarrhea. Hep2 cells are seen here. Viral gastroenteritis. In the viral gastroenteritis, what are the viruses causing? Remember RNTCP, right? You remember, right? What is RNTCP? What I have written here is RNTCP. It is a program which was launched previously. Now it is being updated as NTP. You learn in PSM. So that is a program for TB, RNTCP. R is for rotavirus, N is for norovirus, T is for togavirus, C is for calcivirus, P is for picornavirus. These are the viruses causing the gastroenteritis. Most commonly seen in children, and the most common cause of all is rotavirus. It is icosahedral. It is segmented double-stranded RNA. It is having proteins, structural proteins and non-structural proteins from VP1 to VP7, that is structural, except VP5. There is no VP5. Then non-structural proteins from NSP1 to NSP6. Pathogenesis. First fecal-oral entry is seen, then they are going to destroy the enterocytes and they are going to multiply in the cytoplasm of the enterocytes, then damage the transport mechanism and cause secretory diarrhea. So after this, what does it do? NSP4, that is non-structural protein 4, what is it going to do? That will act like a enterotoxin and increase the cell permeability, leading to excess infection. Clinical manifestations. Since it is a GI, you are going to write vomiting, specifically watery diarrhea here, then fever, abdominal pain are seen. Okay. Lab diagnosis, electron microscopy, you are going to see sharp edged triple shelled struck capsid, that is spike wheel pattern. Okay, spike wheel pattern. Then antigen detection by ELISA, then RT-PCR antibody detection by ELISA. This is common. Okay, antigen detection, antibody detection is done by ELISA. Then PCR. These are the 3 molecular methods and immunological methods. Then supportive treatment. There is no antiviral, so I am going to do the supportive treatment with electrolytes and intravenous fluids. Coming to the food poisoning causing organisms. What are the organisms causing the food poisoning? One is Bacillus cereus, then Staphylococcus aureus, botulinum, cholera, giardia and rotaviruses are the food poison causing organisms that leading to gastroenteritis. So cholera is basically the next question which you are going to deal. Again, it is in the part of GIT. So here we are going to deal regarding the cholera, which is the most common thing you are going to focus here. Cholera is basically a most commonly encountered, most common cause of diarrhea in entire India. So you are going to do the typing there. So Vibria is mainly Vibrio cholera and other types. In the Vibrio cholera, sub-serotypes are O1, O131 and non-O1 and non-131. Okay. Biotypes are classical type and ultra type. Ultra type was more famously seen in West Bengal, whereas classical in other parts of India. Serotypes are Ogawa, Inaba and Ecojima are the serotypes. Pathogenesis. What is a pathogenesis? Pathogenesis being a mode of transmission is by ingestion. Infected dose is 10 to the power 8. Risk factors is again hypochloremia and use of antacids. So they are going to cross it. They are going to cross the protective layer of mucus due to increased motility. Because of what? Increased motility, that is called as darting motility, which you are going to see in hanging dog preparation. And because of enzymes such as mucinase and proteinase, they are going to remove the mucinous protection. Okay, mucinous protection is being removed by all this activity. One, it is highly active, then mucinase enzyme and protease enzyme. Then adhesion and colonization. Next is adhesion and colonization. So after getting adhered and colonized, it is going to produce a cholera toxin. That is a enterotoxin. It has two fragments, as I told before, A and B. Cholera toxin A is going to cause ADP ribosylation, and it is going to stimulate the adenylate cyclase, and that will lead to increase in the CAMP. So if there is increase in the CAMP levels, then that will lead to diarrhea. Whereas fragment B, it is going to bind to GM1 gangliosides of the intestinal epithelial cells. What are the other virulence factors? If you want, you can write. One is endotoxin produced by the LPS, then colonizing factors and zoonoccludens toxins. What are the clinical manifestations? Most commonly it is asymptomatic. Okay, then you're going to see typically rice water stool. Okay, if they are going to give rice water stool or fish in stream appearance or watery diarrhea, that is of rice water stool. Okay, it is typical for cholera. You're going to see rice in the stool as if the fish is flowing in a stream. Then vomiting, nausea, abdominal cramps, malaise, fatigue, tachycardia, sunken eyeballs, and decreased urine output are the things you're going to observe. Humans are the reservoirs here. The source is asymptomatic carriers or cases. Then season, most commonly it is seen in summers. Okay, then heavy rainfall, then flooding climates. In environment, usually most commonly poor sanitized areas, poverty, overcrowding, all these are the things you're going to remember. Then risk factors. What are the basic risk factors here? In immunocompromised patients such as HIV, O blood group patients, and malnutrition. Lab diagnosis, you're going to collect the specimen from stool or rectal swab. Okay, stool or rectal swab. Then coming to the transport media, it is VR media, that is Venkatesh Ramanan media and Kerry Blair media. VR media, I don't know the full form, please just check out the VR media full form. Then direct microscopy, you're going to see the gram negative rods which are slightly curved and comma shaped. Okay, slightly curved and comma shaped. I told hanging dropping will show darting motility. Culture enrichment broth is alkaline peptone water. Selective media is bile salt agar and TCBS, where you're going to see the yellow colonies. Okay, remember yellow colonies are seen in TCBS, which is very specific. If it is sucrose fermenting, if it is not sucrose fermenting, it will lead to green colonies. Okay, they are called as others. Okay, then McConkey agar, it will produce non-lactose fermenting colonies. It is going to produce non-lactose fermenting colonies. Biochemical reactions being, okay, indole positive, citrate positive, urease negative, and TSI acid by acid with gas negative and H2S negative. There it is gas was positive. Here there is no gas positive, no H2S positive. Okay, these are the things you're going to see. Then coming to the string test, which is being positive, the C and O is catalase and oxidase positive. String test positive, again hemodiazation on blood agar. Biotyping, you're going to see the classical and enterotypes. If you're going to serotype, you're going to see O1 and O131. Antigen detection again by cholera dipstick assay and molecular PCR. Treatment, how you are going to treat the patient? Basically, in the severe cases, you are going to give the IV fluids. If it is mild and moderate, it is ORS sufficient. Then azithromycin and erythromycins can be given. Azithromycin or erythromycin. Doxycycline or tetracycline are used as chemoprophylaxis. They are used as prophylaxis. Doxycycline or tetracycline. Then prevention is by provision of safe water. You are going to drink the safe water. Then improved sanitations, food sanitation. Then prompt outbreak investigation. You are going to investigate properly for any outbreak in the areas. Then vaccines, killed whole cell vaccine and oral live attenuated vaccines are approved, okay, for cholera. Next, coming to H. pylori, that is acid peptic disease. which is been caused by gram-negative bacilli. Basically, first it is colonization. Okay, all it is for all first step is colonization. Remember, then it is adhering, then entering inside using enzymes, and after adhering to the mucosa, causing to effects. Then it is highly motile. Since it is highly motile, it is easily coming inside. Okay, it is going to invaginate. Then later it will produce enzymes called as urease and arginase, and because of this it is going to create a faithful environment as it. Urease will keep the environment alkaline for its growth. Because stomach being acidic, this urease enzyme will start increasing the alkaline nature and support the growth of this H. pylori. That will lead to adhesion of this particular bacteria using adhesins. Then oxidative stress is the last resort. What are the risk factors? Smoking people, high sodium diet people, preserved food. You're going to eat the packed foods from bakery or any outside foods, okay, which are being packed, which is more commonly seen in developed countries such as America, USA, okay, UK, Britain, France, all those. Then protective factors are antioxidants, vitamin C, GERD, Barrett's esophagus, and adenocarcinoma. These are not seen usually. Okay, they are not going to be seen. They are not going to be seen in the future. That is what they mean. They are protective for this. Okay. Then clinical features. Acute gastritis is seen first. Then it is peptic ulcer disease. It is going to cause the ulcer. Most commonly, you are going to see the duodenal ulcer. H. pylori infection will inhibit what? Somatostatin producing cells, and that will lead to increase in the gastrin levels. So, if the gastrin is increasing, that will lead to increase in the HCl, leading to the formation of ulcer. Most commonly, this is a pathogenesis of duodenal ulcer. Gastric ulcer pathogenesis is not explained in detail, so it's better if you are going to remember it as duodenal ulcer. Remember, this is for duodenal ulcer. It is for duodenal ulcer. Then what are the clinical features as mentioned? Epigastric pain, chronic atrophic gastritis, autoimmune gastritis, pernicious anemia because of the alteration of intrinsic factor which has been produced inside the stomach only. Then adenocarcinoma stomach in the future. Then gastric lymphoma. Lab diagnosis, histopathology. You're going to see pink curved rods if you take the biopsy specimen. Then gram stain, you're going to see gram negative bacilli with seagull morphology. You're going to see seagull morphology. Culture, it is most specific using the Skyros media and chocolate agar. CA is for not cancer, it is chocolate agar. Then biopsy, urease test positive. Then urea breath test positive because it is producing urease, right? So the urea will be positive. Remember the tests there. Then fecal antigen assay. Then antibody detection using ELISA. Antigen is used for treatment response and screening. Treatment regimen for H. pylori. One is triple regimen, the other one is quadruple regimen. The triple regimen is OCM, okay, or OCA. Quadruple is Tom regimen. Both are for 14 days. Remember, O is for omeprazole, C is for clarithromycin, M is for metronidazole, A is for amoxicillin. Tom regimen, T is for tetracycline, O is for omeprazole, M is for metronidazole, B is for bismuth salicylate. Okay. So what are the antibiotics which are going to cause the diarrhea? There are three groups, that is high risk, moderate risk and low risk. In the high risk, you are going to see cephalosporins and clindamycin most commonly cause the diarrhea. Then in the moderate, you are going to see ampicillin, macrolides, tetracyclines, fluoroquinolones and cotrimoxazole. Low risk, you are going to see aminoglycosides, vancomycin, metronidazole and rifampicin. Were you able to see that? Yes. Then intestinal amebiasis. Coming to the intestinal amebiasis, parasitic infestations. So Entamoeba histolytica is the cause for amebiasis, that is bacteria, that is parasitic intestinal amebiasis caused by Entamoeba histolytica. It is having three forms, that is tropozoid form, pre-cyst form and cyst form. Okay, tropozoid form is the infective form, cyst is the diagnostic form. Tropozoid is having this type of pseudopodia. This is called as pseudopodia. Okay, pseudopodia is seen. Then you're going to see four quadrinucleated cyst, it is diagnostic. Okay, if you're going to see quadrinucleated cyst, it is blindly going to mask the intestinal amebiasis. What is the mode of transport? Fecal-oral and sexual. Okay, these are the mode of transports. Then coming to the life cycle. So first, the man acquires the infection by ingestion. Okay, there is the ingestion of the water or food which has been contaminated by the mature cyst. Once this cyst enters into the body, what does it do? It is going to cause the excision. So if this excision occurs, what are the trophozoites inside? They are going to be released outside. Trophozoites are released. Okay, so this is excision happens in the small intestine, whereas trophozoites release occurred into the large intestine. Okay, excision in small intestine, tropho for T, colon, okay, T, long, that is large intestine. Then it is going to colonize in the intestinal mucosa. Okay, intestinal mucosa dalli colonize ಆಗ್ತವೆ. Then later, if excision is done, later you're going to see the encystation. You're going to see the encystation. After encystation, the cysts are formed and they are released in the fecus, and that is again been ingested by inoculation or ingestion. Virulence factors of this particular disease, that is intestinal amebiasis, you're going to see the amebic lectin antigen that is leading to adhesion. Then proteinase, hydrolytic enzymes and neuroamidase are the things you're going to see. Pathogenesis. What is the pathogenesis? Colonization. Again, first is colonization, then is adhesion of the trophozoites, then is adhesion of the trophozoites. They penetrate into the mucosal layer. After they penetrate, they cause something called as flash-shaped ulcer with broad base and narrow neck. Remember, they are very classic for intestinal amebiasis. Never forget, that is flash-shaped ulcer. Later, they are going to invade inside and lead to the complications. Okay. Clinical features being amebic dysentery, that is bloody dysentery, then abdominal pain, nausea, vomiting, all this you can write. Then right iliac fossa tenderness and amoeboma, that is pus mass. Okay, amoeboma, that is pus mass caused by Entamoeba histolytica. Since it is an amoeba, it is called as amoeboma. Lab diagnosis: in the wet mount you are going to see cysts and trophozoites directly, and intestinal biopsies also can be done for confirmation. Then stool antigen detection via ELISA and antibody detection by again ELISA, PCR, real-time PCR to quantify it. So if it is tissue, you are going to give it metronidazole. If it is luminal, you are going to give paromomycin. Remember this. Okay, remember this. Okay, tissue infection, metronidazole; luminal infection, paromomycin. Next is giardiasis. Okay, if you are liking the content, please subscribe, like and share. Okay, never forget, with all these efforts, I make sure you come in with the wonderful colors in your university exams, and make sure you're going to utilize these sessions properly and having a blast. Okay, giardiasis, it is caused by Giardia lamblia. Morphology: it is having a pear-shaped trophozoites and tetranucleate cyst. Okay, this is the cyst, this is the trophozoite. Trophozoite is having 2 suckers and 8 flagellas with 1 axostyle, whereas here you are going to see the 4 nuclei and 1 axostyle with loss of flagella, because it is non-motile, it is motile. Then coming to the life cycle. Again, ingestion with contaminated, then excision, trophozoites are released. Once the trophozoites are released, they are going to multiply. After they are multiplying, they adhere. After they adhere, they are going to be released inside the lumen. Once they are released inside the lumen, they are going for jejunum. Okay, jejunum is where you are going to see them. Then later encystation, and cysts are passed in the fecus, and that will lead to again ingestion. This is what the life cycle of giardiasis. So mode of transport, what you are going to see is ingestion is the mode of transport. Infective dose is 10 to 25 cysts. Risk factors is poor hygiene and immunocompromised patients. Clinical features: it is asymptomatic most of the times. If it is acute, you are going to see steatorrhea. If it is chronic, you are going to see smelling diarrhea, foul, flatus, and enteric and arthritis are seen as a part of late complications. Then lab diagnosis is using stool microscopy, that is gold standard. You are going to see the giardia. Wet mount also can be done to see the trophozoite and cyst form. Then antigen and antibody detection using the immunofluorescence assay and ELISA. Okay, these are the classic ones. Then treatment is metronidazole, which is a drug of choice. You can also give tinidazole and nitazoxide. What are the prevention? How are you going to prevent this particular disease? Okay, how are you going to prevent it? GITs with improved food and personal hygiene. Then boiling and filtering. Treatment with the asymptomatic carriers. You are going to prevent the disease. Then coming to the difference between Taenia saginata and Taenia solium. Taenia saginata and Taenia solium. So Taenia saginata, it is short, S for short. Solium, okay. Saginata, ST, short. Solium is for long, LO, soli, long. Remember, okay, it is long. Then head and scolex, it is quadrangular. Okay. Sonium, it is globular. Solium, it is globular. Okay. Remember, cow, it is dum good. Okay. That's why it is globular. Okay. It is round, whereas saginata, it is caused by pig and it is rectangle in shape. Remember, like that, it is small and it is rectangular, whereas cow, it is circular and globular. Coming to the suckers, here it is having 4 suckers. Here there is absence of suckers. Okay, to suck the blood. Then it is hooklets to hold it, to adhere. Okay, hooklets to hook the structure. If suppose this is the intestine, it is going to hook via hooklets, and those hooklets are absent in case of saginata and it is present in case of solium. How many hooklets are present? 2 hooklets are present. Then proglottids, it is more in number here, 1k to 2k, that is 1000 to 2000. Then here it is 800 to 1k. Then Cysticercus bovis. Okay, Cysticercus bovis, that is the larval form here. Here it is Cysticercus cellulae. Okay, cellulose. Okay, cellulose. Then egg, here it is acid fast, saginata. Here it is non-acid fast. Then intestinal teniasis is the thing which has been caused. Here it will cause intestinal teniasis and also cysticercosis. In the complication of cysticercosis is neurocysticercosis, where it is going to enter into the brain. There you are going to give the steroids. Okay, it is very important. Then later you can give albendazole. Coming to the NIH swab, which is being used for diagnosis of the enterobius vermicularis infection, you are going to draw this diagram. This is the test tube with the outer rubber, and you are going to insert the swab inside. This thing what I have mentioned here, what I have drawn inside is swab. Okay, so basically inside it, ultimately last is cellophane, then rubber tube, rubber band or rubber tube, then test tube outside, then glass rod which have been inserted, then rubber and stopper to close the thing. So it is rolled over the perianal skin to diagnose the infection. Coming to the ascaris, the egg of the ascaris is very important for diagnosis. One is fertilized egg, then unfertilized egg, and decorticated egg. This is very neat, right? It is very round, oval. Okay, round to oval, round to oval. It is round to oval. Here it is not, it is rectangular. Here it is rectangular comparatively. It is mammulated and albumous coat is present. Okay, albumous coat is present. It is bile stained here. Here also it is bile stained. Here only you are going to see the albumous coat. Then it is floating. It is floating. F for floating. Okay, unfertilized, not floating, unfloating. Do not float. Do not float. Then decorticated, it is not mammulated also, it is not having any albumous coat, it is just chill. Okay, just round like this. Then hepatitis B virus. So we are done with the GIT. Now we are entering into the hepatobiliary system. So the first thing we are going to see it is hepatitis B virus. Okay, sorry, hepatitis B virus. Sorry for the break. Hepatitis B virus. So it is the only double-stranded DNA. It is the only double-stranded DNA among the hepatitis viruses. You are going to draw the morphology like this. You are going to draw the icosahedral symmetry. You are going to draw the icosahedral symmetry with incomplete partial double-stranded DNA. One DNA you are going to draw it fully. Okay, we are going to draw it fully like this. The other DNA you are going to draw it half. It is going to end here itself. That's why it's called as partial double-stranded DNA. Then you're going to see the outside it is surface antigen, then inside it is core antigen. Before that it is pre-core antigen. Inside you're going to see the DNA polymerase. polymerase and partial double-stranded DNA. So mode of transmission, parental route, sexual route, vertical route, and direct skin to skin contact can be seen. High risk groups. What are the high risk groups here? What are the high risk groups here? Sorry. So what are the high risk groups? Surgeons, technicians, paramedicals, sex workers, homosexual people, and IV drug abusers are the risk factors for this particular hepatitis B virus infection. Remember the epidemiology, that is reservoir is humans, carriers being simple and super. Okay, just remember simple and super. Then clinical manifestation, pre-ectic phase and ectic phase. Pre-ectic phase it is nausea, vomiting and fever. And ectic phase it is jaundice and abdominal pain because the liver is being involved. Complications is fulminant hepatitis, cirrhosis, hepatocellular carcinoma. These are all hepatic complications. Remember, it is hepatic. This is extra hepatic. It is extra hepatic. That is serum sickness, arthritis, and rash. Lab diagnosis, you are going to again do antigen detection, that is HBsAg, HBeAg. These are two which is very important. Okay, if HBsAg is present, it will tell whether it is infection present or not. If HBe is present, it is telling whether the infection is active or not. Then it is antibody detection using anti-HBs, anti-HBe, and anti-HBc. Anti-HBs indicates recovery, anti-HBe indicates low infectivity, anti-HBc will indicate window period diagnosis. Molecular methods are HBV, DNA, and real-time PCR to monitor treatment. So how we are going to remember the serology of HBV? They are going to ask, it is called as sexes. Okay, SECEC, sexes. That is the order of appearance. Okay, order of appearance. So basically, first two are antigens, then next three are antibodies. First is antigen, then it is antibody. To produce the antibody, first there should be some antigen, right? Remember the same way. So first you are going to see the peak. Okay, first you are going to see the peak, that is HBsAg. See, that is S, that is an antigen, right? Then E, you are going to see the peak here, right? The peak here, it is HBe antigen. The peak here is HBe antigen. Then the third peak is C, right? Anti-HBc, C. Okay, anti-HBc. Then you're going to see E. Okay, E. You have seen the anti-HBe here, anti-HBe. The last peak is anti-HBs. That is for S here. Then coming to the treatment, tenofovir is the drug of choice. You can add emtricitabine if there is emtricitabine for HIV positive patients. Plus or minus pegylated. It is not used nowadays because of the complications it is having. Coming to the prognosis of HPV, prophylaxis, not prognosis, prophylaxis. One is active immunization, then other one is passive immunization. Active immunization is you are going to use the recombinant HPV vaccine. You are going to see the route of administration, that is IM here at the deltoid, 10 to 20 microgram. Schedule is 3 doses, that is 0, 1 and 6 months. Under National Immunization Schedule, that is NIS, means Mission Indradhanush, you are going to give it at 6, 10 and 14 weeks with DPT vaccine. Then protection will be confirmed how? If there is anti-HBsAg, the antibody titer should be more than 10. Then coming to the passive immunization, that is you are going to give the immunoglobulins. What are the indications for these? Healthcare workers, sexual contact with HBV positive patient, then Neonates, okay, neonates with the mothers being positive for HPV, you can give 0.06 ml per kg, 0.06 ml per kg or 10 to 12 international units per kg. Not after 7 days, remember, not after 7 days, not after 7 days. You should never give after 7 days, it is not useful. Combined immunization, last is combined immunization, you can give both active and passive. Prevention, screening of blood and its products, and okay, screening and safe sex, safe injection practices, safe aseptic measures, and health education. These are things again. Extraintestinal manifestations of amebiasis, I forgot that I've written here. Amebic hepatitis and abscess, pulmonary amebiasis, cerebral amebiasis, splenic abscess, cutaneous amebiasis, and peritonitis are the complications or the extraintestinal manifestations of amebiasis. Next it is hydrated cyst. So it is a fluid filled cyst. Basically it is a fluid filled cyst. It is unilocular. It is unilocular and spherical. It has cyst wall layers, and those layers are outer pericyst, middle ectocysts, and inner endocysts. Okay. We are going to draw inner endocyst. Inside that you are going to see brood capsules and hydrated sand. Okay, what is brood capsule? There are some complexes inside the endocyst. They are going to produce what? They are going to produce the hydrated fluids. Okay, and they contain also what? Protoscorices. These heads which you are going to see here, right? What I have drawn in this shape. Okay, inside this shape, this shape. Okay, that particular shaped things are called as protoscorices. Okay, then hydrated fluid. Okay, hydrated fluid, it is clear or pale yellow colored, it is toxic and anaphylactic. It can induce type 1 hypersensitivity reaction causing anaphylaxis. What is hydrated sand? Hydrated fluid is done hydrated sand brood capsule. Okay, these are the headings you are going to mention. Hydrated sand is, you are going to see the brood capsules coming out. Okay, out of brood capsules you are going to see the protoscorices coming out, and those protoscorices will deposit in one like a sand. So it's called as hydrated sand. What is the fate of this particular hydrated cyst? One, it undergo resolution, or it undergoes rupture, and it can form secondary cysts. If it forms rupture, it will lead to anaphylaxis. Lab diagnosis of echinococcosis. One is microscopy, you can see wet mount and staining. Then histopath demonstration of the cyst walls. These cyst walls can be seen. Then antibody detection by ELISA. Then imaging techniques such as X-ray and USG. You are going to see the water lily sign, which is very important as a part of your radiology. Water lily signs, there you are going to see, according to WHO, you are going to see it in type 2. Okay. Then CT can also be done. Then molecular techniques such as PCR as usual. Then skin test, which is not done nowadays, that is Cassoni's test, to demonstrate the type 1 hypersensitivity reaction, as it is less sensitive. Okay, now we are done with the GIT and hepatobiliary. So now moving on to the skin. Okay, last aspect of the part 1 microbiology. Please, again I'm mentioning, please subscribe, like and share my channel, and share to the maximum people, so it will be useful. I have concised so beautifully, as I have taken so much of efforts to do it, and I request you people to do the subscribing, sharing and liking work, and please support me for the extraordinary contents in the near future. Okay, please. So diabetic food, right? It is a skin. So diabetic food causing organisms, that is Staph aureus, E. coli, Coagulase negative Staph aureus, Pseudomonas, Klebsiella, Staph epidermidis, Streptococcus pyogenes, and Acinetobacter. All these are normally encountered, right? So you can see them. Then coming to the staph infections per se, let me just check out. Okay. Coming to the staph infections, that is catalase positive and coagulase positive, non-motile, non-sporing. This is about staph, okay, Staphylococcus introduction, and it is a gram positive cocci, gram-positive cocci, which are arranged in clusters. They are arranged in clusters. Okay, they are arranged in clusters like this, something like this. They are arranged in clusters. Coming to the virulence factors, in the virulence factors it is in the cell wall you're going to see protein A and echoic acid, and the toxins that are hemolysins, which are very important, alpha, beta, gamma, delta, and enterotoxins and toxic shock syndrome toxin. Then enzymes, what are the enzymes? Coagulase, protease and DNase are the enzymes. These are all the virulence factor of this particular Staphylococcus. Coming to the toxins and the disease cause, that itself is going to be given as a 5-marker question for you people. So concentrate the toxins which are released by the Staphylococcus I am going to mention now. So membrane active toxins, that is hemolysins and leukocidins. So what these toxins do, in the name itself they are going to do hemolysis. They are going to damage the membrane of the RBCs, that is leading to the hemolysis. Leukocidins, it is also called as Panton-Valentine toxin. It is most commonly expressed in MRSA, that is methicillin resistant Staph aureus. It is going to increase the gamma hemolysis. Once this gamma hemolysis is that will lead to damaging of the leukocytes, RBCs and the macrophages. Okay. Epidermolytic exfoliative toxin is the other toxin which is responsible for staphylococcal scarlet skin syndrome. Okay, Staphylococcus scarlet skin syndrome. It has 2 subunits, that is A and B. It is not sufficient, you need the function of it. It is most commonly seen in newborns and children. Remember, it is seen in case of newborn and children. Localized tensed blisters. Okay, localized tensed blisters and bullae formation is seen, and they exfoliate in the near future, and that is called as Nikolsky sign, and that sign is called as Nikolsky's sign. It spares the mucus. Okay, it spares mucous membrane. The severe form is called as Ritter's syndrome. Ritter's, not Ritus. Okay, Ritus is different again. Ritter's syndrome, that is called as fever, lethargy and irritability and poor feeding. You are going to see all the CNS symptoms here, right? That's why it is severe. Then mild form is skin involvement, that is pemphigus neonatorum and bullous impetigo. Coming to the next toxin, that is enterotoxin. Enterotoxin is responsible for what? Food poisoning. It is a preformed toxin. Most common serotype is A, that will cause food poisoning, but F, instead of having F in it, it is not causing food poisoning, but it is causing toxic shock syndrome. Then next is toxic shock syndrome toxin. Which is responsible for toxic shock syndrome. The toxin is responsible for toxic shock syndrome, and the toxin for it is toxic shock syndrome toxin, that is TSST. Then subtypes, there are 1 and 2. Okay, 1 is very important because that is perfect staph enterotoxin, and it is most commonly seen in case of menstruating females. Okay, and post surgery, trauma patients, burn patients, this particular toxin is getting activated. So what is the pathogenesis? This particular TSS1, that is TSS1 T1, that is a super antigen. I have told super antigen is going to stimulate the T helper cells directly without the help of APCs that I mentioned in the immunology, right? So what does this T helper cells do? They are going to secrete the massive cytokines. Once this massive cytokines are released, what they do? They are going to stimulate the B cells. These B cells, the plasma cells, what they do? They produce the antibodies and they are going to kill the antigen. Then what are the clinical features? Fever, hypotension, diarrhea, confusion, myalgia, abdominal pain, erythematous rash are the clinical features. Detection is done by latex agglutination test and ELISA to detect this toxin. Okay, we are going to detect the toxin and PCR. Clindamycin and vancomycin are the treatment. Okay, clindamycin and the vancomycin. If it is associated with MRSA, it is vancomycin you are going to give. Pathogenesis. First again colonization, then introduction into the tissues, then invasion. After invasion, it is going to evasion of host defense. Okay, evasion of host defense mechanism by a 2. Okay, one is antiphagocytic and inhibition of leukocyte migration, and last it is going to cause the metastatic spread, that is hematogenous. Then coming to the clinical manifestations caused by the Staphylococcus, skin and soft tissue, it is folliculitis, okay, infection of the hair follicle, furunculosis, that is infection of the hair follicle inside the external ear, that is called as furuncle, okay, furunculosis. Then carbuncle, then abscess, that is pus formation mass, then impetigo and cellulitis. Then in the musculoskeletal system you will see septic arthritis, osteomyelitis and abscesses. Then respiratory system, pneumonia and nematocele, most common against Staphylococcus. The cause you are going to see the nematocele inside the lung. Diffused, it is sepsis and infective endocarditis and catheter, okay, central line associated infection, okay, central line associated. I told it in the hospital acquired infection, right? In components of HAI there are 4 components, okay. This is one, okay, central line associated bacterial site infection, okay. Then toxin mediated, what is the toxin which is going to mediate this? It is TSS, okay. Then food poisoning, enterotoxin and SSS using the other toxin. UTI is the other thing which has been caused. Then MRSA strains, most commonly they are going to cause necrotizing pneumonia and necrotizing fasciitis. Lab diagnosis being sample collection by the wound. Then direct microscopy you are going to see the gram-positive cocci arranged in clusters. Then culture, nutrient agar you are going to see golden yellow pigmented colonies, and blood agar you are going to see beta hemolytic colonies. Then selective media is mannitol salt agar and Ludlam's media. Then McConkey, it is lactose fermenting pink colonies are seen. Biochemical reactions. What are the biochemical reactions? Catalase positive, coagulase positive, that is tube coagulase positive and slide coagulase positive, and protein A detection by the PCR, that is also nucleic acid amplification test as a part of biochemical reaction. Then treatment, penicillin G, okay, is the usual treatment for penicillin sensitive. If it is not penicillin sensitive, you are going to methicillin sensitive, then you are going to give nafcillin and fluoxacillin. If it is not sensitive, it is not sensitive for methicillin, that is called as methicillin resistant Staph aureus. For that you are going to give vancomycin. All these are the serious infection, so you are going to give it IV. MRSA, they are going to ask it for 3 marks, okay, they are going to ask it for 3 marks. So basically, what is MRSA? MRSA is a methicillin resistant Staph aureus. So what does it do? It is going to code MEC-A gene. If this gene is coded by this particular Staph aureus, it is going to alter what? Penicillin binding protein, and that will inhibit the cell wall synthesis. Once the cell wall synthesis is inhibited, it is going to cause the defective organism. So what are the risk factors? Again, poor hygiene and the injured risk, okay, injury risk. Coming to the types, what are the types? Again, community acquired and acquired, okay, in the community and it is acquired. Subtypes are not required for people. If you want, you can just see here. So detection, then what is the detection here? Antibiotic susceptibility testing and PCR is used to detect the gene, and latex agglutination test to detect the protein, that is the abnormal protein binding, penicillin binding proteins, that is PBP2A, remember 2A. Treatment is vancomycin is the drug of choice here. The other drugs which can be used are linezolid and daptomycin. Linezolid and daptomycin can also be used. What are the control measures? You are going to screen the MRSA carriers. You are going to do the screening of the MRSA carriers. You are going to treat them also using the mipirocin and chlorhexidine. Mipirocin for nasal carriers and chlorhexidine for general carriers. Stop unwanted antibiotic use. Don't use antibiotics simply, that will cause a resistance in your body. That's what we say repeatedly. Don't take antibiotics for simple infections. Then hygiene practices are also very much important. Coming to the streptococcal infections. So what are the streptococcal infections which you are going to see? We'll deal. So catalase negative, then gram positive cocci which are arranged in pairs or chains, okay, they are arranged in chains. They are arranged in chains like this in a line. They are arranged in chains. They are arranged in chains. Then virulence factors being in the cell wall, you're going to see the M protein and capsule. M protein in the capsule. Toxins are hemolysins and streptococcus pyogenetic exotoxin. Streptococcus pyogenetic exotoxin. What are the enzymes? Streptokinase, DNase and hyaluronidase are the enzymes there. What are the clinical manifestations? Suppurative infection and non-suppurative infections, which separately they have been asked for 3 marks. So please concentrate what are the suppurative infections, what are the non-suppurative infections. In the RS, that is respiratory system, pharyngitis and scarlet fever are most commonly seen. It is simple sore throat. Okay. Then soft tissue and skin, you are going to see impetigo and cellulitis. For the deep tissue, that is necrotizing fasciitis. Then toxic shock syndrome. Then sepsis. These are the suppurative infections, whereas non-suppurative is acute rheumatic fever, acute glomerular nephritis, that is PSGN. Then reactive arthritis and psoriasis are the non-suppurative infections. Then coming to the lab diagnosis of this particular streptococcus, one is specimen collection, that is depending on the site. Then direct smear, you are going to see the pus cells with GPCs in chains. Then culture, you are going to see blood agar, that is beta hemolysis is seen. Then selective media is crystal violet blood agar. Biochemical reactions, you are going to see what? That is catalase negative, bacitracin sensitive. Remember, it is bacitracin sensitive. And camp test is negative. Serology, you are going to see the ASO titers, that is anti-streptolysin antibodies, they are going to be increased, and antibiotic susceptibility testing is done at last to see the susceptibility. Then treatment of this particular diseases such as impetigo, impetigo and PSGN, you are going to give the benzathine penicillin or oral penicillin. Then erysipelas and cellulitis, you are going to give procaine penicillin or penicillin G if severe. Necrotizing fasciitis, it is surgical debridement as soon as possible, and penicillin G with clindamycin. Coming to the streptococcus toxic shock syndrome, that will lead to penicillin G and clindamycin with immunoglobulin IV. So camp test, they are going to ask, so what is the camp factor present? The camp factor is important here. Because of this camp factor only, the phospholipase which is being produced by group B streptococcus, that is Streptococcus agalactiaceae, it is been formed. Okay, the scientists were Christie, Atkins, Munch and Peterson. These were the 4 scientists. So it's called as camp test. So what they do, they're going to, this particular camp factor is going to enhance the hemolysis. It is going to enhance the hemolysis of Staph aureus. It is produced by group B streptococcus, that is Streptococcus agalactiaceae. So what you are going to do in this particular camp test is, first you are going to streak the Staph aureus in a parallel manner. You are going to streak here. What I mentioned here is that is Staph aureus. For them in the perpendicular, you are going to stick to, one is Streptococcus agalactiaceae, that is group B streptococcus. The other one is Streptococcus pyogenes, that is group A streptococcus. So the growth of this particular Streptococcus agalactiaceae will be leading to arrowhead hemolysis, that is camp test is positive in case of group B, whereas it is negative in case of group A. Gas gangrene. So remember, gas gangrene is a 10 marker. They will give history of RTA or crush injury for this. Okay, there must be RTA, that is road traffic accident, or there should be a crush injury. If there is a mention of this thing, then it is sure that you are dealing with this condition. Then what is the definition of this? Rapidly spreading edematous myonecrosis associated with severe crush injury caused by Clostridium perfringens. Okay, what is the causative organism here? Clostridium perfringens. What is the pathogenesis? First I have told you, that is crush injury or the RTA. Because of something, the bone or the thing is crushed. Okay, that is crushed, that is called as crush injury. And if there is a crush injury, that will lead to decrease in the blood supply and ischemia, and the contamination of wound with spores. Okay, contamination of wound with spores which are present in the mud. Basically that will lead to toxin production, leading to gangrene. Okay, leading to gangrene. Toxins produced are alpha toxin and theta toxin, which are very important for you. This alpha toxin will contain phospholipase C and sphingomyelinase. What that will do? That will cause platelet adhesion and decrease myocyte contractility and decrease BP. Then theta toxin will cause marked vasodilatation. What are the clinical manifestation? Excruciating pain, which is sudden in nature, okay, and foul smelling serosanguinous discharge. Okay, it is foul smelling serosanguinous discharge you are going to see, and you are going to see the crepitus, that is gas bubbles. It is going to make sounds like that. Okay, so much of crepitus is seen, okay, as if something is there. Okay, this is how you, this is how. Okay, then edema and induration, edema and induration as a part of inflammation. Then shock and organ failure in the last stages. And then coming to the lab diagnosis. In the lab diagnosis, the specimens are collected from the necrotic tissue. You are going to see thick boxcar shaped gram-positive cocci without spores. Remember, it is without spores. The others are, other clostridiums are spore forming, but this perfringens doesn't form any spores. Okay, culture, I have told it is an anaerobic, so I am going to use the Robertson cooked meat broth and egg yolk agar. Identification, target hemolysis, Naegele's reaction, and reverse chem test being positive here. So basically here you are going to see the double zone hemolysis. If suppose this is one hemolysis, if suppose this is the thing and this is one hemolysis, and again other hemolysis is seen, that is called as target hemolysis. Naegele's reaction is, I am going to explain in detail in the future, that is the near future. Then river camps positive. There again you are going to streak the Clostridium perfringens in a parallel manner, and you are going to streak the whom? Streptococcus agalactiaceae, that is group B Streptococcus perpendicularly, and you are going to see the arrowhead colonies here. Arrowhead colonies are formed, and the test is positive there. So treatment of this particular thing. Okay, what is the treatment? One is early surgical debridement. Okay, early surgical debridement. Then penicillin plus clindamycin. Then hyperbaric oxygen is given. Then passive immunization with antitoxin. Okay, anti-alpha toxin anti-serum is given. What is Naegele's reaction now? That is asked for 3 marks. Okay, this has been asked for 3 marks. Remember, this has been asked for 3 marks. So what are the things you are going to focus here and write? Basically, it is the Clostridium perfringens which produces the opalescence. Okay, Clostridium perfringens is seen, and you are going to streak it properly in the media, and opalescence is seen. Based on the presence and absence of penicillin, you are going to demonstrate the alpha toxin, whether it is present or not. Okay, if suppose there is a opalescence present, that indicates the alpha toxin is present. The alpha toxin is present. Because of that alpha toxin, there is no growth of this particular thing. Okay, that is Clostridium perfringens. Then if it is no alpha toxin, that is due to antitoxin, opalescence is negative. Coming to the next part of skin, that is Vincent's angina. In the Vincent's angina, it is acute necrotizing ulcerative gingivitis. Okay, acute necrotizing ulcerative gingivitis. So gingivitis, painful bleeding from gums and foul breath, all these are the complications. Pseudomembrane, okay, pseudomembrane, write down. Pseudomembrane is very important here, which is similar to diphtheria, but peels off easily. Causative agent is Borrelia. Okay, Borrelia vincenti and Fusobacterium species. Both of these together will form this Vincent's angina. Diagnosis is, since Borrelia is a spirochete, you are going to do the dark brown microscopy to identify the spirochetes using the silver impregnation. Then fusiform bacilli are also seen, okay, using the microscopy. Debridement with metronidazole, okay, and penicillin is the treatment of choice for Vincent's angina. Next is leprosy. I am not going to read leprosy in detail because it is a part of skin which will be mainly asked in your dermatology postings. So here we are going to concentrate on the diagnosis of leprosy. So in the lab diagnosis, first thing you are going to see is smear. You are going to see acid fast bacilli which are arranged in a cigar bundle, okay, like a cigar bundle. You are going to see the pink bacteria, okay, like a pink bacteria in a cigar bundle. bundle. That is what you are going to see. Then mouse pad food culture, then antibody detection via fluorescent antibody absorption, then ELISA, then lepromin test. Coming to the lepromin test, that is important. What is lepromin test? It is going to demonstrate the delayed hypersensitivity reaction. It indicates the intact host immunity. If this test is positive, it indicates the host immunity is good or intact. It is not useful in acute. Then it is used to classify lesions. Whether it is tuberculoid or lepromatous leprosy. Then it is used for prognosis indication. Okay, it is used for prognosis indication. If this is positive, I told the cell mediated immunity is intact, and that is tuberculoid. Okay, that is tuberculoid leprosy, and that is good prognosis. What is two types of reactions? One is early, that is 48 and 21 days reaction. 48 early reaction is called as Fernandez reaction, whereas 21 late is called as Bistuda reaction. Okay, here you are going to see the induration more than 10 mm. Here you are going to see the nodule which is more than 5 mm. So this is what about leprosy. Next, anthrax. Next is anthrax. In the anthrax, again it is a spore forming bacilli, that is a Bacillus anthrax is the causative agent here. Okay, I have not written the causative agent. Please write down the causative agent. The causative agent is Bacillus anthrax. Coming to the other feature, it is obligate aerobe. If remember, you can write. Then virulence factors. What are the virulence factors? Basically, one it is toxin, the other one it is capsule. Okay, toxins I'll tell you. First it is capsule. The capsule itself is a protecting factor or the virulence factor. Edema factor, protective factor, and lethal factor are the part of toxins. Whereas transmission, mainly it is entry of the spore to the abraded skin or inhalation and ingestion. Ingestion will lead to intestinal, inhalation will lead to pulmonary, direct contact to skin will lead to cutaneous. That is what are the types. Okay, that is what the types. Cutaneous anthrax are being acted and most commonly seen. That is Hyder-Potter's disease. It's called as Hyder-Potter's disease. You're going to see a typical malignant pustule. How are you going to differentiate? How are you going to define it? It is a papule which evolves into painless vesicle. First it will be a papule, then it will become a vesicle that is painless, followed by formation of eschar. Eschar is a darkish pigmentation scar leading to edema also. Seen most commonly in whom? The people who are going to handle the vegetables and fruits, that is butcher and farmer, we are going to do farm activities. Most common. Okay, it is a most common type of anthrax. Then it is self-limiting. But rarely fatal. It is associated with bioterrorism. So what is the specimen you are going to use? Pus, sputum or blood. Direct microscopy you are going to see. You are going to do gram stain, where you are going to see the gram positive bacilli which are rectangular in shape, and direct immunofluorescence can also be seen. Then you are going to do the Macfadden staining to stain the capsule detection. Then culture. What is basically the culture here? It is medusa head colonies in the nutrient agar, then string of pearl appearance, inverted fur tree appearance in case of gelatin stab agar. Antibody detection again ELISA, NAT is for PCR. Cutaneous treatment is amoxicillin. Remember, one drug it is sufficient. Cutaneous is amoxicillin. Okay, pulmonary is again you are going to give the antibiotics with immunoglobulin. You are going to add the immunoglobulins here. Then post exposure prophylaxis you can give ciprofloxacin or doxycycline for 60 days with vaccine. Okay, you must give the vaccine which is including 3 doses. Coming to the prevention of this, you are going to dispose the animal feces particles by burning, then decontamination, protective clothing and gloves. Okay, actinomycetes. What is actinomycetes? Actinomycetes is a gram positive bacilli in chains or branching filaments. You are going to see branching filaments. Okay, it is very peculiar, and it is not acid fast, so it will not look red. It will look like a bluish thing. Okay, it will look like a bluish thing. So don't forget, they are the filamentous bacteria. There are filamentous bacteria. They're going to look it like this. Don't confuse with the fungi, which are same way hyphal forms. This is a bacteria and it is non-acid fast. Coming to the infection caused, it is called as actinomyces, that is chronic suppurative and granulomatous infection with multiple abscesses, sinuses and discharging granules. Okay, discharging sinuses and granules. Commensals are the mode of transmission and endogenous. It is endogenous itself. What are the clinical features? Orocervicofacial actinomycosis, that is lumpy jaw. Lumpy jaw. Okay, lumpy jaw. Painless hard mass. Painless hard mass. Other forms are thoracic, abdominal, pelvic and brain. Okay, you're going to suffix it with by actinomycosis, that is thoracic actinomycosis, abdominal actinomycosis, pelvic actinomycosis, brain abscesses. Then again, lab diagnosis. In the lab diagnosis, what you're going to do? The direct microscopy. There you're going to see the gram-positive branching filamentous. Okay, branching filamentous bacilli. Culture. Actinomyces being anaerobic, you're going to give thioglycolate broth, where you're going to see the fluffy balls. Then BHI agar, where you're going to see the spidery colonies. You're going to see the spider, right? You know how the spider will look, right? Suppose this is the body of the spider. It is going to have like this. Same way, this is filamentous and it is having sundry appearance. Never forget, all the filamentous bacteria will have the sundry appearances. That is nocardia, actinomyces, all these will have the factors of sundry appearance because of this filaments that look like a ray of sun. Then treatment: IV ampicillin or penicillin G. Okay, followed by, it is going to be followed by oral penicillin. Remember, oral penicillin is must for follow-up. Then doxycycline and ceftriaxone are the alternative. You can also do the surgical removal. For extensive lesions. Then coming to the viruses. In the viruses, we are going to concentrate mainly two things. One is HSV, skin infection, and measles. These are the two things we are going to do. So in the HSV, that is a spherical. Okay, it is spherical, it is round, right? That is spherical. Icosahedral. Then double stranded DNA. You are going to see the double stranded DNA inside, right? That is double stranded DNA. So you are going to label it same way. The outer bilayer lipid and glycoprotein, both of these forming the envelope. Then tegmentum, which is in the middle, that is the tegmentum. Then innermost linear double stranded DNA with icosahedral capsid. What are the types? Type 1 and type 2. Type 1 is direct spread, type 2 is sexual spread. Here it is having trigeminal latency, here it is having sacral latency. Most commonly HSVs will be affecting the above vest, such as orofacial mucous lesions, encephalitis, meningitis, ocular lesions, whereas HSV2 is below vest, that is genital lesions. Coming to the lab diagnosis, which is very specific, that is Zank smear, that is cytopathology. You're going to do the scrapings from the base of skin. Okay, scrapings from the base of the lesion skin of that is taken, and you're going to stain with Gimsha. Okay, you're going to stain with Gimsha or Pap stain, that is Papinicolia stain. It is less sensitive. Remember, it is less sensitive. So that's why, since it is less sensitive, it cannot differentiate between HSV1, HSV2 and zoster infections of the skin. So basically, what you're going to see the Cowdery A Lipkels bodies in case of HSV, that is intranuclear inclusions. Then multinucleated Jane cells with ground glass chromatin, that is Zank cells, which are typically seen in case of Zank smear. Okay, Zank cells are seen. Then virus isolation using the McCullough cell lines. Then virus antigen detection by ELISA. Then HSV DNA detection. Then antibody detection by ELISA again. CP. So in the McCullough, you're going to see the virus isolation. In the general virology, I mentioned the cytopathic effect. What are the cytopathic effects? There are so many cytopathic effects. Here the cytopathic effect seen is diffuse rounding and ballooning. What is the treatment of this particular HSV infection? Acyclovir. Prevention is using of condoms to prevent the sexual transmission, and acyclovir prophylaxis to the mothers who are positive for HSV infection to prevent the infection going to the baby. This is what you are going to do. Then coming to the measles. In the measles, it is highly contagious childhood disease. It is characterized by triad fever, respiratory difficulty, and maculopapular rash. What is the mode of transport? It is droplet inhalation. Spread is respiratory tract is been colonized. First colonize in the respiratory tract, then go to the nearby lymph node and enter to the bloodstream. Then later in that is primary viremia once it is leading to bloodstream infection. Then entering into the reticuloendothelial system, leading to the later coming out from the spleen, leading to secondary viremia and dissemination. So clinical manifestations are prodromal stage, eruptive stage, and post-measles stage. In the prodromal stage, what you are going to see is fever and Koplik spots, whereas in eruptive, the name itself says you are going to see the rash, that is maculopapular, just behind the ears. That is very specific, just behind the ears. Okay. In post-measles, you are going to see weight loss and fatigue as a part of symptoms. Complications, you are going to see otitis media, which is the most common complication which is encountered in the measles. Then vitamin A deficiency because of plenty of diarrhea. Then bronchopneumonia. Then croup, that is tracheobronchiolitis. Then subacute sclerosing panencephalitis. It is a chronic complication. Okay, after so many years, it will lead to the chronic complication called SSPE. Lab diagnosis, again specimen is going to be collected. You are going to detect the antigen detection via ELISA. Then virus isolation using the monkey human kidney cell line. Notice the cytopathic effect seen here is Warthin-Finkelday cells. Okay, what you are going to see specifically, Warthin-Finkelday cells. They are endocytoplasmic and intranuclear inclusions. I have told two diseases, one is CMV, other one is measles, which contain both the inclusion bodies I mentioned in the previous video. Then antibody detection again by ELISA and RT-PCR. Treatment and prevention, basically there is no antiretroviral, so supportive treatment is given. Vitamin A is very crucial. Okay, vitamin A can be given prophylaxis. That's why MMR vaccine would be given with vitamin A, you remember, right? And that the 9 months you went to the MMR vaccine, and vitamin A prophylaxis is given as per national immunization schedule to prevent all this. Then hygiene is important, personal protective equipment, and MMR vaccine. These are the things you are going to concentrate as a part of viral. Coming to the last, fungal skin infections, that is mycetoma. Chronic slowly progressive granulomatous infection of the skin and subcutaneous tissue. Chronic slowly progressive and granulomatous. Okay, it's chronic slowly progressive granulomatous infection of skin and soft tissue. So what is a triad basically? One is swelling, the sweet will get swelled, then it is having discharging sinuses, then granules coming out of the sinus. So basically there are the types of mycetoma. One is eumycetoma, other one is actinomycetoma. Eumycetoma is caused by fungi, actinomycetoma is caused by bacteria. So what are the causes there again? Madurella, okay, Madurella mycetomatous, okay, Madurella mycetomatous and Aspergillus are the most common causes of eumycetoma, whereas actinomycetoma you are going to see the actinomycetes as a cause. So fungi will have black and white granules. Remember, fungi is black and white granules, whereas bacteria you are going to see yellow and red granules. What are the clinical manifestation? You are going to see tumor-like swelling, discharging sinuses and granules. This is a triad, classical triad, never forget. That is tumor, there is some swelling with discharging sinuses and granules. This is very typical for mycetoma. Okay, and specimen collection, okay, from lesions. That is how we are going to diagnose. And direct examination, not immunography, sorry. Direct examination, you are going to see the color, size, shape. It is a clinical diagnosis, right? You are going to see the swelling, you are going to see the discharging sinuses, and you are going to see the granules, which color they are. If they are black and white, it is fungi. If it is red or yellow, it is bacteria again. So culture, you are going to do it on Saburans agar. You are going to see the colonies with conidia formation. Treatment of this particular mycetoma is itraconazole or amphotericin B, that is as an antifungal. If if it is actinomycetoma, you are going to give amikacin plus cotrimoxazole. So okay. Sporotrichosis. It is a subcutaneous nodulo-ulcerative lesion. It is a subcutaneous nodulo-ulcerative lesion. It is called as Rose-Gardner's disease. It is also called as Rose-Gardner's disease. I have not written here. Please, you are going to write it. It is a Rose-Gardner's disease because it is very common in case of people who are doing gardening. Okay. If they are giving any history of gardening in your question, it indicates it is sporotrichosis for sure. So what is the causative agent here? Sporothrix shenkai, which is a type of dimorphic fungi. What is the pathogenesis? First you have to do the minor trauma. Most common is thorn pick. So after this, the sporothrix shenkai is going to enter inside and it will produce enzymes such as proteases and proteinase. So what these enzymes do? They help in local invasion. Coming to the clinical manifestations of this particular sporotrichosis, one is lymphocutaneous type. That is the most common type which you are going to encounter. It is having nodulo-ulcerative lesions which are painless, and lymphadenopathy. In case of RS, it is COPD and AIDS. Disseminated. Lab diagnosis is direct microscopy. KOH mount, you are going to see the yeast cells. Then HPE will reveal asteroid bodies. Then culture, that is aberrant extracellular hyphae form, yeast form, which I have explained in detail. Hyphae will have petaloid conidia and moist creamy colonies in case of yeast. Then latex agglutination tests to detect the serum antibodies. Treatment is itraconazole. For disseminated, you are going to give the amphotericin B. Dermatophysis. What is dermatophysis? Phytosis. It is a superficial skin infection, that is tinea or ringworm. That is most commonly encountered, okay, basically in the most of the southern countries because of the humid climate. Most common. It is again most common superficial mycosis, which is affecting the skin, hair and nail. Organisms which are causing this is trichophyton, epidermophyton and microsporum. Okay, repeat: trichophyton, epidermophyton, microsporum. These are the organs. Remember TEM. So what is the skin lesions here? Basically, you are going to see the annular or ring-like lesions. What is the diagnosis? Wood lamp is positive. You need not know the appearance in the wood lamp. That is not necessary for you. So wood lamp is positive for whom? T and M. T is trichophyton. M is microsporum. Then direct examination with KOH mount. Then LPCB. LPCB is lactophenol cotton blue. I told it is used to demonstrate spores. So septal hyphae with condia. That is two types of condia are seen. That is microconidia and microconidia. They are seen as a part of culture diagnosis. Then PCR. Okay, PCR. It is dictum. You are going to write in your PCR irrespective of anything. Okay. Then hair perforation test, which is very specific. Treatment being itraconazole, griseofulmin and ketoconazole. If it is present, it is itraconazole only you must give. Okay, it is the drug of choice. So this is what I have dealt here. In the next part, I will be dealing in the second part of the systemic microbiology. I will be dealing the other systems such as respiratory system. Okay, then central nervous system, and genitourinary system, eye, ear, congenital infections, cancer causing agents, then zoonotic disorders, opportunistic infections, then bioterrorism agents, vector transmitted diseases and blood transmitted diseases. All will be dealt in the next part. Okay, so until then, see you people. Make sure you utilize it. I'll be back with the next content. Please, if you are liking my content, please like, share and subscribe to the other friends of you and family members whoso is interested regarding the content of it. Okay, then till then, see you guys. Bye.